Hello friends, today we are going to discuss the fluid therapy in ICU. So physiology of the fluid administration. In general, the main goal of the fluid administration is to ensure adequate tissue perfusion by increasing intravascular volume. According to the Frank-Starling mechanism, in normal heart, the resulting increase in the preload leads to the increased cardiac output. The final goal is thus the adequate oxygen delivery. The most common clinical scenarios that requires immediate fluid resuscitation are hypovolemic shock due to hemorrhage by trauma and major surgery, or due to extravascular loss in the systemic inflammatory reaction such as sepsis and burn patient. The response to the fluid administration depends upon the cardiac function and baseline preload. Therefore, in patient with the normal cardiac function may become non-responsive to fluid if flat part of Frank-Starling curve has been already reached after increasing preload. The second determinant of the efficacy of the fluid administration is duration of the intravascular volume expansion following fluid administration. The physiological principle of early fluid therapy was also based on experiment by the Starling. The vascular permeable membrane and the interplay between hydrostatic pressure and oncotic pressure are responsible for the fluid shift between the various physiological compartments according to the principle. So these ideas have recently been revised with greater appreciation of the role of endothelial glycocalyx. This is the complex layer with the multiple function, and it consists of glycoprotein and proteoglycan on the luminal side, which play a key role in regulating vascular permeability. So in critically ill patients, especially in sepsis and severe trauma, this layer may be damaged, leading to the alteration in the vascular permeability, resulting into the increased transcapillary escape of albumin, which is the major oncotic constituent in the plasma. Increased rate of the fluid loss from the intravascular space into extravascular space have direct impact on the need of fluid administration because duration of its effect is diminished. This leads to the need for the further fluid administration. This situation may be associated with increased risk of fluid overload. Another important aspect among those mentioned above, especially when it comes to repeated fluid bolus administration, is peripheral arterial resistance. In a study by Monge Garcia et al. In septic shock patients, fluid administration resulted in improved cardiac output, but reduced arterial load, and therefore did not improve blood pressure. Consequently, studies indicates that further fluid boluses are not as effective as in initial phase, even in so-called responders. So this is the Frank-Starling curve. As we can see, the fluid, when we have given fluid boluses, the preload is increasing, and corresponding there is increase in the cardiac output, uh, which falls into the this which shown by the rising curve of the Frank-Starling law. But after some time, when the patient is becoming to preload independent, then in this phase the patient is fluid unresponsive, and it falls into the steep curve of the Frank-Starling law. The another reason for the steep Frank-Starling law curve is when the patient's cardiac output, cardiac contractility is the poor, and when we are administering fluid. So there won't be corresponding increase in the cardiac output in response to the preload, which will result into the falling into the steep part of the Frank-Starling curve. So rationale of using the fluid. Hypotension and oliguria are the most frequent indication for fluid prescription. There are no universally accepted target for administration of resuscitation fluid, which makes it challenging for clinician to determine right amount of the fluid therapy for individual patient. This increases the potential for over-administration of IV fluid. Studies clearly indicate that not only too little but also too much fluid may lead to the additional harm in critically ill. Administration of the too much fluid may lead to formation of edema, which can negatively affect the function of various organs such as lungs, kidney, particularly in sepsis and in ARDS. This is also the case in perioperative setting where hypervolemia has been associated with increased mortality rates. In early phase of treatment, it is undoubtedly important to act quickly as resuscitation phase moves into maintenance phase. A more nuanced approach to fluid therapy is warranted, with specific therapeutic target becoming more important. So the right amount of the fluid is still the matter of ongoing discussion. For initial resuscitation in septic shock, the Surviving Sepsis campaign recommends 30 ml per kg in first 3 hours. Moreover, after this initial fluid bolus, repeated lactate measurement are recommended as parameter for adequate therapy. In addition, other clinical examinations such as CVP, echocardiography, invasive hemodynamic monitoring, or simple assessment of capillary refill time are available as potential target for individualization of the fluid strategies. Interestingly, the recently published Conservative versus Liberal Approach for Fluid Therapy of Septic Shock in Intensive Care, that is classic trial, which investigate the effect of restrictive volume administration, showed no difference in outcome compared to the standard fluid therapy. So there are 4 Ds for the fluid administration, that is drug, dosing, duration, and the deresuscitation. So, the commonly administered fluid in ICU are crystalloids and colloids. And there are 4 indications for administration of the fluid, which are resuscitation, maintenance, replacement, and nutrition. So, regarding crystalloids, these are most commonly used resuscitation fluid uh, in ICU, and there is evidence that support the idea that choice of crystalloid over fluid therapy does not matter, and in fact, it makes the clinically important difference. Most data suggest that IV fluid containing relatively physiological chloride concentration are probably the right initial choice in adult ICU patients. A notable exception are patients with traumatic brain injury, patients with the prolonged vomiting and excessive losses of gastric juice, and patients who are hyponatremic as well as hypochloremic. So these patients should receive 0.9% of saline. Now, electrolyte content available in the crystal. In general, there are 2 broad categories of the crystalloid preparation available in the ICU. These categories are physiologically buffered preparation that contain electrolytes and buffer in such a concentration that they approximate those found in normal human plasma. The other category is neither buffered nor balanced, and it does not contain physiological concentration of electrons. Therefore, they are, however, more isotonic and thus will not lyse RBCs when administered intravenously. So, fluids such as 0.9% saline may lead to generation of hyperchloremic metabolic acidosis, which is dose dependent. So it is a chloride load that is thought to lead adverse effect observed in patients given moderate to large doses of high chloride containing fluid such as 0.9% saline. The underlying pathophysiology is not entirely clear, and the opinion differ on whether precise mechanism is related to arterial vasoconstriction or immune-mediated problem that makes patient more susceptible to damage associated and pathogen associated molecular pattern induced insult. So these are various studies which compared balanced crystalloid and 0.9% saline. So among these studies, only SMART trial showed the benefit of using balanced crystalloid solution, and the rest, which are the rest trials like SALT trial, basic trial, plus trial, did not show any difference between balanced crystalloid and 0.9% saline. Now the next fluid is colloid. Colloid are the IV fluid that contains high molecular weight microscopic substance suspended in the crystalloid solution. So colloids were introduced into the clinical practice because of their theoretical ability to retain in the intravascular space for long period of time than crystalloid due to presence of macromolecule in solution, which creates greater osmotic pressure in the circulation. So because of their high molecular weight, colloid substances penetrate healthy semi-permeable endothelial barrier only slowly. Thus, crystalloid electrolyte solution distribute evenly to intravascular and extravascular spaces. So colloids are intended to achieve selective expansion of intravascular space due to oncotic grade. This effect is partially lost with inflammation, altered vascular permeability. An advantage of colloid solution in the fluid therapy is their volume saving effect. So theoretically, the volume of colloid requires to maintain same intravascular filling is up to 3 times smaller than that of the crystal. However, the advantage is lost when the endothelial glycocalyx is damaged by inflammatory condition, although to different extent. Indeed, despite their theoretical advantage, colloids have not generally proved effective in critically ill patients. At present, there are no data to support routine use of colloid for volume resuscitation. So, colloid can be divided into semi-synthetic hydroxymethyl starch, gelatin, dextran solution, and natural, that is human albumin solution. So both type of colloid have found widespread clinical use because of their stronger volume expanding effect than could be achieved with the crystal. So semi-synthetic colloid are preferred because they were comparable in efficiency but cheaper and more readily available than their natural counterpart. Of semi-synthetic colloid, it was hydroxyethyl starch that was preferably used in many countries for decades. So there are many trials which compared hydroxyethyl starch versus crystalloid. So according to this trial, the crystal trial which compared colloid versus crystalloid, which showed no difference in 90-day mortality. Uh, uh, but there was no difference as such, but 90-day mortality was lower in colloid. Then the chest trial published, which compared this hydroxyethyl starch versus saline, which showed no difference in mortality, but the hydroxyethyl starch was associated with more adverse effect. Then there is success trial which was published in 2012, which compared hydroxyethyl starch and the ringer lactate, which showed the increased risk of death and more RRT in hydroxyethyl starch group. Then VSEP trial was published in 2008, that is, which compared 10% hydroxyethyl starch versus ringer lactate, and it shows the increased rate of AKI and RRT in hydroxyethyl starch. Then, in context of albumin, there are two trials was published. One was SAFE trial and other was Albios trial. The SAFE trial showed no difference in higher mortality in subgroup of patients in traumatic brain injury. So after publishment of the SAFE trial, the albumin was not useful in traumatic brain injury, but it was useful in the septic patient. Then Albios trial was published, which showed no difference in mortality when they have compared albumin versus 20% albumin with the crystal. Now the next is duration. Longer the delay in fluid administration, the more microcirculatory hypoperfusion and subsequent organ damage related to ischemia reperfusion injury. So in patient with sepsis, Murphy and colleague compared the outcome related to early adequate versus early conservative and late conservative versus late liberal fluid administration and found that combination of early adequate and late conservative fluid management carried the best prognosis. Combined data from other studies confirm that late conservative is more important than the early adequate fluid therapy. So septic shock starts with if phase, which refers to the phase when the patient showed hyperdynamic shock with decreased systemic vascular resistance due to vasodilatation and increased capillary permeability and severe absolute and relative intravascular hypovolemia. So, Surviving Sepsis campaign minded the administration of IV fluid at the dose of 30 ml per kg given within first 3 hours as possible life-saving procedure in this phase. Although there is no randomized control trial to support this statement. The flow phase refers to the phase after initial stabilization, where patient will mobilize the excessive fluid spontaneously. A classic example is when patient enters polyuric phase, recovering from the acute kidney injury. In this post-shock phase, the metabolic turnover is increased and the innate immune system is activated and hepatic acute phase response is included. This catabolic metabolic rate is characterized by the increase in oxygen consumption and energy expenditure. Then the next concept is the global increased permeability syndrome. So some patient will not transgress into flow phase spontaneously and will remain into the persistent state of global increased permeability syndrome and ongoing fluid accumulation. So the global increased permeability syndrome can therefore be defined as fluid overload in combination with the new onset organ failure. This is referred as third hit of shock. In some patients, volume expansion increases mean systemic filling pressure, but it increases right atrial pressure and to some extent, such that venous return. Therefore, cardiac output do not increase. So, about fluid responsiveness, it indicates that the condition in which patient will respond to fluid administration by significantly increasing stroke volume and cardiac output or their surrogate. A threshold of 15% is most often used for this definition as it is least significant change of measurement of the technique that are often used to estimate cardiac output. So physiologically, fluid responsiveness means that cardiac output depends on cardiac preload, that is slope of Frank-Starling relationship. It's steep. Many studies have shown that fluid responsiveness, which is normal physiological condition, exists in only half of the patient receiving fluid challenge in ICU in intensive care unit. As we will discuss below, the final step in the fluid therapy is to consider withholding and withdrawing resuscitation fluid when there are no longer required. Like for antibiotic, the duration of the fluid therapy must be as short as possible, and the volume must be tapered when the shock is reversed. However, many clinicians use certain trigger to start, but are unaware of the trigger to stop fluid resuscitation, which increasing the potential for the fluid overload. As with duration of antibiotic, although there are no strong evidences and there is trend towards shorter duration of intravenous fluid. So there are four phases of the fluid resuscitation. That is resuscitation phase, optimization phase, stabilization phase, and evacuation phase. So resuscitation phase after first hit, which can be sepsis, but can also burn, pancreatitis, trauma. The patient will enter the if phase of the shock. It is the life-threatening phase of severe circulatory shock that can occur within the minute and characterized by the strong vasodilation, leading to the low mean arterial pressure and microcirculatory impairment. It may be accompanied by high and low cardiac output. At this initial phase, usually during first 3 to 6 hours after initiation of therapy, fluid resuscitation is commonly administered according to the early adequate goal-directed fluid management strategy. As a result, early goal-directed therapy was incorporated into resuscitation bundle into first 6 hours of sepsis management adopted by surviving sepsis camp. And the modality of the fluid administration at this phase have been a matter of great debate. So, in the context of early goal-directed fluid therapy, the multiple trials were published, which include Process trial, Promise trial, and Arise trial. And none of these trials showed beneficial effect of early goal-directed fluid therapy. A recent study employing combined Bayesian and the frequentistic methodological approach to evaluate 12 randomized trials and 31 observational studies found that early goal-directed therapy was potentially harmful in patients with highest disease severity. What remains from early goal-directed therapy debate is that Rapidity of the fluid administration and of achievement of hemodynamic goal for initial resuscitation is important, even though this aspect has also recently been called into question. At the very initial phase of septic shock, answering the question is easy. Fluid administration will significantly increase cardiac output in almost all cases. Nevertheless, after first bolus of the fluid, likelihood of preload unresponsiveness is high. Therefore, we advocate the use of specific tests to increase the prior probability and likelihood for favorable event and outcome, as fluid administration should be limited to responders. Instead of using static marker of the cardiac preload, which do not reliably predict fluid responsiveness, one should use dynamic indices to predict the fluid responsiveness. The principle of these indices is to observe the effect of cardiac output of changes in cardiac preload, either spontaneously induced during mechanical ventilation or provoked by some manners. If changes are larger than the given threshold, preload responsiveness is preset and positive response to the fluid is likely. Now about fluid bolus. Fluid bolus is the rapid infusion of the fluid over a short period of time. In clinical practice, the fluid bolus is usually given to correct hypovolemia, hypotension, and inadequate blood flow or impaired microcirculatory perfusion. The volume of the fluid bolus is heterogeneous among clinicians, usually 500 to 1000 ml. The minimum fluid volume that is able to increase backward pressure of venous return is 4 ml per kg. Then there are certain tests to assess the fluid response, like pulse pressure and stroke volume variation, inferior vena cava diameter variation, and all these two tests it cannot be used in case of spontaneous breathing, cardiac arrhythmias, and low tidal volume. Then superior vena cava variation, it requires performing transesophageal Doppler, and it cannot be used in case of spontaneous breathing, low tidal volume, and low lung compliance. Then passive leg raising, it requires direct measurement of cardiac output. Then end expiratory occlusion test, it cannot be used in non-intubated patient, and it cannot be used in patient who interrupt 15-second respiratory hold. Then mini fluid challenge, it requires precise technique for measuring cardiac output. Conventional fluid challenge, that is 500, it requires direct measurement of cardiac output and induces fluid overload if repeated. Then the next phase is optimization phase. The second hit occurs within the hour, refers to ischemia and reperfusion. At this phase, the fluid accumulation reflects the severity of illness and might be considered biomarker for it. The greater the fluid requirement, sicker the patient, and the more likely organ failure may occur. So in this phase, we must try to find answer to the second question, that when to stop fluid therapy. Indices for fluid responsiveness are again utmost important, since fluid administration should be stopped when these indices become negative. Second, clinical context must be taken into account. Obviously, more fluid is needed in septic shock from peritonitis than from pneumonia. Third, the decision to refrain from the fluid administration should be based on indices that indicate the risk of excessive fluid administration. The presence of lung impairment is the condition that is more likely to be associated with worse consequences of fluid overload. Then the third is stabilization phase. With successful treatment, stabilization should follow optimization phase and evolving into next few days. It is distinguished from the prior to by absence of shock or the imminent threat of the shock. As previously described, the focus is now on the organ support, and this phase reflects the point at which patient is in a stable, steady state. So fluid therapy is now only needed for ongoing maintenance in setting of normal fluid loss, and replacement fluid if the patient is experiencing ongoing loss because of unresolved pathological process. Since persistence of positive daily fluid balance over time is strongly associated with high mortality rate in septic shock, and clinicians should also be aware of Hidden obligatory fluid intake as it may contribute more than liter daily. Maintenance fluid should be used only to cover daily needs, and their prescription should take these other sources of fluid and electrolyte into account. Therefore, when patient already receives daily need of the water, glucose and electrolyte via other means, specific intravenous maintenance fluid should be stopped. Now, fourth is evacuation phase. After the second hit, the patient may either further recover and entering the flow phase with spontaneous evacuation of excessive fluid that have been administered previously, or as in the cases in many critically ill patients, the patient remains in no flow state, followed by third hit, usually resulting from global increased permeability syndrome with ongoing fluid accumulation due to capillary leak. In any case, patient enters the phase of deresuscitation. It specifically refers to the late goal-directed fluid removal and late conservative fluid management. The late goal-directed fluid removal involves aggressive and active fluid removal using diuretic and renal replacement therapy with net ultrafiltration. It is characterized by the discontinuation of invasive therapy and transition to the negative fluid balance. Late conservative fluid management describes moderate fluid management strategy following initial treatment in order to avoid fluid over. Recent studies showed that 2 consecutive days of negative fluid balance within first week of intensive care unit stay is strong and independent predictor of survival. So in this deresuscitation phase, we try to answer to the third and fourth question, when to start fluid removal and when to stop fluid removal, in order to find the balance between the benefit and the risk of fluid removal. To answer this question, testing preload responsiveness may still be useful. So indeed, if no preload responsiveness is detected, it is reasonable to assume that fluid removal will not induce reduction in the cardiac output. On the opposite, positive indices of preload responsiveness might indicate the limit of fluid removal and could even be target to reach when removing fluid. So obviously the risk at this phase is to be the too aggressive with the fluid removal and to induce hypovolemia, which may trigger the fourth hit for hemodynamic deterioration and hypoperfusion. Its prognostic impact might be significant because it may lead to reduction in cumulative fluid balance, which by itself is clearly associated with poor response. Similar principles have also been suggested by others, confirming the need for multicenter prospective clinical trials with biphasic fluid therapy approach, starting with initial early adequate goal-directed treatment, followed by late conservative fluid management in those patients not transgressing spontaneously from the ape to the flu phase. Thank you, guys.